Hi, I'm Christophe Lambert from the University of New Mexico Health Sciences Center, and along with my collaborators, I'd like to present our work on detecting PTSD and self-harm among U.S. veterans using positive, unlabeled learning. What if you were given a set of people with confirmed diagnosis of a condition, another set of people where the condition's unknown, and covariates consistently characterizing both sets of people? What if you also could rank those unknown people by the probability of the condition, estimate the true proportion of the condition among the unknowns, and do this without any chart review? What could you do with this? Well, you could inform disease screening. You could estimate disease incidence using only confirmed cases. You could discover and correct data quality problems with missing phenotypes, find people falling through the cracks of the healthcare system, economize on chart review and clinician diagnosis. And as we showed in a paper this year, we can increase the power in comparative effectiveness studies by using an imputed outcome to compare treatments, in this case, for risk of self-harm. That sounds good, but how can you possibly differentiate between positives or cases and negatives or controls with no confirmed negatives? What if the condition is uncommon or rare? How can you trust your estimates without chart review? And what are the limits of the method where it might fail? The positive unlabeled learning algorithm I'll present involves you take a set of positives, a set of unlabeled observations that's a mix of positives, class 1, and negative, class 0. You use a cross-validated machine learning model to differentiate between these two. You use those probabilities in a density estimation approach to get the proportion alpha of positives amongst the unlabeled, and of course the negatives or controls is 1 minus alpha. What you do is you take the probabilities from the machine learning algorithm, you use density estimation for the positives and in red, the unlabeled in black, and you basically have to scale the positives such that when you subtract positives from the unlabeled, the estimated control density does not go negative. So here we've overestimated the proportion of positives. And here we got it just right. And we see the true control density in green matches the estimated control density in blue. And so we have 10% positives, 90% negatives among the unlabeled in black. And it's the sum of the red and the blue. We estimate that alpha by finding the inflection point of the error function using a finite difference approximation. We've applied our algorithm in simulated data with low abundance positives of 1% up to 30% and find that the true answer falls right within the error bars across the entire range of fractions that we simulated. A leading method called CleanLab is systematically biased upwards, which really drove us to innovate this algorithm. Most methods, including both of these, use the selected completely at random assumption. It's very important where positives are equally likely to be selected for labeling, which may not hold in electronic health records or most phenotypes. We applied this method to 50% of the Veterans Health Administration population in the US, where we use the data on 2.6 million veterans, 1.39% who had coded self-harm, which is our positives, and the rest would be our unlabeled. We used non-self-harm conditions, observations, and procedure covariates that were OMOP mapped over the entire history of patient observation. And then we used an average over 70 different XGBoost balanced models in 2 split sample train test runs. We used those probabilities in the algorithm I just described, as well as reviewed charts on 50 individuals with probable but uncoded self-harm. The positive unlabeled method estimated 0.43% of uncoded patients had self-harm, which appears to be an underestimate because chart review showed when we selected among unlabeled individuals that 94% of them had clear evidence in their notes of either attempts of suicide or of self-harm. So it appears here the SCAR assumption doesn't hold. Our set of positives of what people pick up as obvious self-harm is not representative of all of the positives among the unlabeled. We've applied our technique to post-traumatic stress disorder and found that when you're dealing with an undiagnosed condition as opposed to one that wasn't coded, you have to deal very carefully with the time windows to make sure that when you discover undiagnosed conditions, you can't use covariates indicative of the treatment for the condition. I'll leave it to our poster to talk in more detail about this, of how we essentially match time windows for cases and controls prior to PTSD discovery for cases and picking an appropriate window for controls so that we could do an apples to apples comparison. When we sort this all out and apply this technique in post-traumatic stress disorder within a quarter of the VHA population, we applied a very similar approach and saw that 7.5% of veterans without diagnosed PTSD have the condition. We also see that among those who were positive versus who later converted in a holdout year that we didn't use for labeling anybody versus those who didn't convert, that the probabilities among the positives versus converters was quite similar and the non-converters was quite low. Chart review showed 36% had positive screens, 3 subsequently diagnosed, and 32 had low evidence of PTSD. To summarize, phenotype incidence estimation with only positives is feasible but has limits. If the SCAR assumption holds, our PU learning algorithm has outstanding performance even with low incidence phenotypes. However, for self-harm in the VHA, the selected completely at random assumption seems to fail and chart reviews required to estimate incidence. For PTSD, the SCAR assumption appears to roughly hold, likely due to an annual screening policy. Further work's needed to address non-SCAR phenotypes. I invite you to see more details at our poster presentation, and I thank you for your attention.